Hello everyone, this is Alraies from SCAI in Phoenix 2023. I'm very privileged today to be with Dr. Alexander Fanaroff. He is one of the late breaker presenters for the registry for CLI. Alexander, nice to meet you with us.
Yeah, thanks for having me.
Yeah. So tell us about, congrats first of all on being picked for a late breaker at SCAI 2023. Tell us a little bit about the idea before we dive into the findings.
Yeah, so the idea, what we tried to do is make a quality improvement cohort for patients with chronic limb-threatening ischemia, which, as you know, a fairly common, fairly morbid, actually highly morbid disease that can lead to amputation and really reduce quality of life for patients that have it. And with other disease processes, myocardial infarction, stroke, heart failure, we have these sort of process metrics for how we take care of these patients, which has helped us to improve the quality of care for the patients when we take care of them. Right. There's really nothing similar for CLTI, and so what we really set out to do was just develop a cohort using Medicare claims data so that we can really start to look at what process measures help people with CLI.
No. So this will help the physician to guide the therapy, or when to refer the patient for CLI therapy?
Yeah, so it's really both. So what we've really done is we created this cohort, and the idea is that you can use that then to look at process measures for CLI. So what improves outcomes in CLI? We know vascularization is what people need for CLI, but we don't know, how long can you wait? Does it matter if you wait longer? How is seeing a vascular surgeon or an interventional cardiologist sooner better?
Would it help you?
Does that help outcomes? And I think that's really what ultimately this cohort is going to help us do.
Yeah. So what did you find?
Yeah, so what we've done now is we really just defined this cohort. So we used really extensive manual review of ICD-9 and ICD-10 claims to sort of define what we think a patient with CLTI looks like in Medicare claims data. And so we used Medicare claims, so we used those claims that we defined, plus patients had to have a PAD imaging test within 6 months of having those diagnostic claims.
CT angiogram.
Right, CT angiogram, ultrasound, ABIs, things like that.
Yeah.
And so when we did that, we found that there was about 1.1 million patients in Medicare between 2010 and 2019 that have this diagnosis of CLI. And then we just described who they were. So we looked at their demographics, we looked at comorbidities, things like that, and then we looked at their outcomes. And so what we found is that, as expected, this is an older adult population. The mean age was 75. 14% of them were Black, which is, compared with 7% sort of the overall Medicare fee-for-service population.
14 or 14?
14, yeah.
14, yeah.
About half of them have diabetes, 25% of them have chronic kidney disease, and then we found that their outcomes are bad. So when you look at long-term follow-up, 17% are dead at 1 year, 50% are dead at 5 years. Wow. You look at amputation, about 3% of amputations in the first 6 months, and then about 1% per year after that. And then, and when you look at Rutherford class measure of CLI severity, patients with higher Rutherford class have worse outcomes. And so what this really, and the importance of this is really that we've created a cohort that we think, consists of patients with CLI. We have 10-year follow-up. We have inpatient and outpatient claims. And then the next step is to say, well, how do we identify process measures that improve outcomes in this cohort?
Exactly.
And then, the next step after that is to say, well, how do we implement process measures, like door to balloon time? We have an MI which really improved outcomes in MI. How do we implement something like that in CLI to improve outcomes in this disease process that's, understudied, affects, people that are, don't really have access to healthcare, and is really terribly morbid and affects lives in a terrible way.
And I think part of it is, I don't know, it's lack of awareness.
Yeah.
As you said, the patient have an ulcer, they neglect it, they go to a doctor, they said you needed to see a podiatrist, they don't go, and it's kind of the snowball effect, and the patient just...
Right, so it's this really fragmented care system for CLI, and it's really a forgotten disease process. And I hope that what we're doing, with this late breaker, with this cohort, is bringing attention to the problem. And then I hope that what we can do going forward is really develop ways to take better care of these patients to improve outcomes, because and develop incentives for health systems and other actors to develop processes of care that take better care of patients
and
like
one
this.
thing you mentioned very interesting is door-to-balloon time for myocardium.
Yeah.
We need to develop same thing. We know a lot of door-to-balloon and what's the outcome of heart,
Right.
but nothing about the CLI.
Right, and I think that's, when you think about what the process measure is for so the obvious one that jumps out is, what's your door-to-balloon time? Does it matter in CLI? And I think it probably does, and that's sort of where we're going next with this.
And create a CLI center like STEMI centers.
Right.
Not every hospital has a STEMI program.
Right.
Same thing. You have to find a center of excellence in the areas and stuff like that.
Right, and it's so much. It's even harder than STEMI because it's multiple processes. It's not only so it's a diagnosis, it's a revascularization, it's wound care, it's changing medicine. So it's a hard problem. But what I'm hopeful for is that this is the first step in solving
it has
it.
a associated bad outcome. 40% in 5 years. That's a lot.
Right. Yeah.
Well, thanks so much for your hard work and congratulations for the award. Please watch this and others on SCAI-TV 2023 videos. This is Alraies from Phoenix. Alex, thanks so much for being here.
Thanks for having me.
Yeah, thank you.